Hi, I'm Sonu Jain at Ohio State University, and I'd like to welcome you all to the fifth in our series, Hand in Hand combined series with, this one is with the American Society for Surgery of the Hand. We're going to be talking today about the international outreach in hand surgery, knowledge and involvement. And I'd like to introduce our moderator, Ryan Schmucker.
All right. Thanks, Dr. Jain. I'm very excited for this panel tonight. We have a spectacular group of speakers talking about a topic that I'm very passionate about personally, and that is international outreach in hand surgery. I think we as hand surgeons are uniquely positioned to help alleviate the global burden of surgical disease using all the tools in our armamentarium. And in the past 10 years, the public health sector has really taken notice about the surgical disease is a public health crisis, with over 5 billion people lacking surgical care that's affordable and safe worldwide, which is over half of the world's population. And so tonight we're going to hear about some ways we can help alleviate this as hand surgeons. So we're going to start out with Dr. Fraser Leversedge as Professor and Chief of Hand Surgery at University of Colorado, talking about the history of outreach in hand surgery. Go ahead, Dr. Leversedge.
Great. Well, thank you, Ryan, and thank you, everybody, for participating. My task was to review the history of outreach in hand surgery. And I think it's somewhat of a formidable task. There's actually not a lot written about it, but there's some great anecdotal passed down stories. There's some wonderful discussion in the literature as you comb through it about the history both of hand surgery and outreach. And I think, and this is my disclosure slide, which has already been presented, but I think that part of our history of hand surgery outreach really goes from what motivates us to do what we do. And I think we're in a unique position as hand surgeons to try to reconstruct function, get people back to participating in their communities, their workplace, their society. And I think that when we go on these trips, I think that there's many anecdotes and great, wonderful, inspirational phrases that you can see here to really travel the world, but sometimes actually traveling next door and domestically. And that's actually really where we sort of started. And I'm going to give you a quick perspective of my own outreach history, because I think we'll all have our sense of history and why it affects us. This was me when I was a chief resident. I went to Lima, Peru. It's a fairly impoverished city. At that time, we had a very large public hospital, very similar to my hospital where I did my residency at Grady Hospital. But it gave me an opportunity to see what outreach was really, what enticed people to do outreach. And from a history standpoint, why would people venture across borders to places which were really in need? And you can see here that you sometimes had to reach outside the box and do things that you weren't necessarily familiar with, or use techniques that were sort of maybe not as traditional as we anticipate. But it gave us opportunities to teach, and even as a chief resident, being able to show somebody how to do a groin flap to help cover a hand was really an inspiration for me. You figured out that you had to innovate. And so from a historical perspective, many of the things that we do in hand surgery, being able to innovate and take care of the sort of multidisciplinary look at upper extremity surgery. And this was a wound in Lima, Peru. And you might look at this as sort of like the first wound vac. I'm sure other people have done that before, but it gave you a sense of innovation. As Scott Cozen mentioned, what makes us, in a sense, drink the Kool-Aid. And from a historical perspective, there were things that really inspired those that came before us in terms of outreach. I now go down to Honduras, which is where I've been a team leader, so to speak, or leading a trip to Honduras from 2004. Scott Cozen and I went down to the present, and we go down roughly twice a year. And again, very similar to Peru, I learned that you have to do a needs assessment to figure out what's needed and how can we help the local environment grow with capacity and be able to essentially take over what we're doing. So this was very similar for hand surgery, and the early perhaps reaching out that hand surgeons did really came with the beginning of our specialty. And at the end of the Second World War, Sterling Bennell was approached by Dr. Kirk, an orthopedic surgeon and a general, because he had noticed at 78 different hospitals around the country how poorly kept the hand surgery or hand injuries had been taken care of. And he wanted someone like Sterling Bennell to essentially create a structure for hand surgery. And in this way, this was really the first reaching out to a domestic need for our returning veterans from World War II. And so Sterling Bennell was able to establish multiple hand centers with his colleagues, ultimately leading to the first meeting of the Hand Society back in 1946. Prior to this and subsequent to this, a lot of what America, if you would, provided in terms of outreach was both food relief and medical relief in terms of pharmaceutical relief around the world, particularly after the First and Second World Wars. And what this did as a specialty from orthopedics was it lent itself to essentially seeing places in need. And in 1958, the Orthopedics Letters Club was formed, and Dr. Alan McElvey traveled to Jordan and Jerusalem, and he took with him this notion of the Orthopedics Letters Club, which really shared information amongst colleagues in the United States. And he saw that the need in Jordan and Jerusalem was spectacular for very essentially underprivileged and underdeveloped countries in terms of hand surgery. And so he inspired his Overseas Letter Club to develop an outreach, which ultimately became Orthopedics Overseas in 1963. And essentially, this grew as people took up the cause and would spend 6 weeks in Jordan, Jerusalem initially, and then this spread to Africa and other nations that required assistance from a medical standpoint. As Orthopedics Overseas grew, it separated from these cooperatives and American Relief and Medical International Cooperative, and essentially transitioned to Health Volunteers Overseas. And in 1996, Orthopedic Overseas became the founding division of Health Volunteers Overseas, which essentially has multiple divisions, which, as we know from going on trips, requires multiple specialty involvement, such as anesthesia, therapy, and nursing. On our other side, if you think of hand surgery as multi-specialty, Interplast was started in 1969. Don Laub from Stanford University and Robert Chase took on a patient from Mexico with a unique cleft palate and really started this notion of outreach, which ultimately Interplast transitioned to become Research International. And we have obviously a link with that through many of our members that participate in research. Dr. Chang, our 72nd ASSH president, has been research CMO for some time. And there are other links to other organizations: Healing Hands, Cure International, the World Pediatric Project. Obviously, we think many developing nations need assistance with congenital deformity, and this is something which has taken on shape from two emerging organizations, one in Richmond, Virginia, and St. Louis. And many of our members in the ASSH and AAHS are part of this World Pediatric Project. The Touching Hands Project, which is I'm very familiar with, and many of you are familiar with, was born out of the development, effectively, of a presidential line initiative. And Dr. Kozin, our 68th president, was really sort of both a strong advocate for international outreach. But at that time, there were other members of council that also were pushing for domestic outreach, and probably for litigious reasons or worries, and some structural issues in terms of local surgeons having American surgeons coming into their neck of woods, so to speak. The focus initially with the Touching Hands Project really became more one of an international outreach. And so in 2010, as the Hand Society transformed from its traditional pillars of research, education, and practice, it added two additional pillars, one being organizational excellence and one being outreach. And Don Lalonde, who's on the conference call today, was actually the first ASSH Outreach Division Director in 2018, and really took on the challenge of really creating the governance and organizational structure for the Touching Hands, which Dr. Katarincic, also on the call, has taken over and really continued to develop for us. And so this was sort of the development of the Touching Hands project. Again, this was initially a domestic opportunity, which has now continued for hand surgery days across the country. Many volunteers from both private and academic groups around the country have hosted domestic opportunities, and also providing an international commitment for the Touching Hands project. The inaugural brigade for the Touching Hands project was in 2014, 4 years after the earthquake that we all are familiar with, but with really devastating conditions for the group. And there was a lot of lessons learned from this initial trip, both in terms of how do we sort of maintain the continuity of care, how do we look to teach, and how do we learn to educate, but also how do we learn to sustain ourselves as a group, as the Touching Hands project. And so from that, there were several different directions. One was seeking mentorship and guidance. And so engaging other outreach groups such as Operation Smile, Bill McGee started in 1982 and really has an incredible infrastructure for supporting outreach. And so they were a tremendous, provided tremendous mentorship and guidance, really leading to the successful next steps of the Touching Hands project. Coincidentally, in the 2014 Lancet Commission report, outreach and global health was a focus in looking at value. And I think this is important from, even though it's a recent historical event, it really demonstrated that surgical care could actually provide a very significant impact on local community development based on the very poor populations receiving a very limited amount of health care. The Touching Hands project also sought to grow through collaboration through outside organizations, learning to provide coordinated patient care with other groups that were in the same location or the same country and looking to take care of patients over a longer period of time. It's also learned to develop industry partners, even going back to Benel's time, where you look to have institutional partners to develop sites of care and hand centers. Our industry partners have been important to this, as well as local corporations and healthcare on the ground in the places where the Touching Hands project has gone. As part of our history, we want to sort of be able to leave a legacy, no different than what Sterling Benel and others have left for us to grow on. And this leaving a legacy is now turned the Touching Hands project into Touching Hands, which is the next step, if you would, of our sort of endeavor with growing outreach, both around the world and domestically in North America. And that involves building capacity. And our goal is to build and develop a site where we can appreciate a needs assessment. And through building trust and establishing a vision with the local community, we can hopefully improve the capacity of the local surgeons and healthcare providers to essentially take over our position. That includes providing opportunities for preventative care, providing education for local providers that spend time at a mission or in a brigade, and also at a society level, being able to give opportunities for educational workshops and hands-on surgical skills, essentially to teach a man to fish or teach a woman to fish. And then you have to embrace culture. And I think that as visitors, we have to respect the role that we play in education and hopefully inspiring healthcare providers and younger folks to learn to take over what we're there to do. And I'm sure the other discussions following mine will take that concept and expand on that. But as we go on these trips, I hope people appreciate that this is our history that we're developing, no different than those from back in the 1940s through 60s, and being able to leave a legacy of education, being able to improve the capacity of those that we work with in these different sites around the world. And I'll leave you with this, just a note from somebody who joined us on one of our mission trips, which really is why, coming back around to why we do these trips, it's not only the historical importance of developing the capacity in the sites where we visit, but also taking back and building our own characters and coming back and being better surgeons and clinicians back at home as well. So I will stop there, and I appreciate everyone's attention to that brief history of outreach, both domestically and for foreign outreach.
Thanks very much, Dr. Leversedge. That was a spectacular talk and a great basis for the background of what we're talking about today. So next will be Julie Katarincic, professor at Brown University, talking about a very important topic of responsible paradigm in international outreach.
Thank you. Just Ryan, give me 1 second. I was just joking. I have no kids, no fellows. This is a struggle for me to get this going. There we go. Again, thank you for inviting me. I'm excited to be involved. This is obviously a passion of mine, like the majority of us on the call. I did have to look up what responsible paradigm was as I was putting this talk together, and kind of came up with something along the title of care of accountability. You know, with limited resources, what can we do to provide care and teaching that's sustainable? And a lot of this is not repetitive to what Fraser said, but repeated themes. So I think it's important that everyone takes that away. I do have a conflict. I'm director of outreach, trying to follow in Dr. Lalonde's footsteps. It's been a great experience for me. So I'm going to a little bit of commentary, a little bit of literature, and then just some follow-up comments. Kind of why do we do this? There's two reasons. There's extrinsic and intrinsic reasons. You know, ultimately we want to provide care. We want to teach the local physicians, residents, therapists. This is a combination of didactic teaching in the clinics, the operating room, and potentially that may morph into travel to the US of these people we want to educate. I also think there's value in teaching us, you know, US residents, US fellows, US attendees, the variety of cases as things we don't see at home. You really learn to work within limited resources. You don't need as much as you think you do to do an excellent operation. And you learn a lot from local physicians. They've had to do things without some of the luxuries we've had, and they're very savvy. Intrinsics, obviously, why we all went into medicine. I think it gets harder and harder as medicine becomes more non-patient care focused, and this is kind of a reprieve. You know, I think it does help burnout. It kind of recharges, and it's nice to get your family involved and show your teenagers especially that we really have a good gig in the United States and Canada and in the higher income countries. The real question is, are we making a difference? We think we are. We could probably have better outcome data for this. So this is, I think, something kind of a goal of mine for the next 5 years or so. If we can find a better way to collect this data, I think we can be more powerful in where we choose to use our resources. Because the WHO, even way back in 2005, said this global surgery is important. We need to pursue it. Just a few comments on goals for me. You know, I think the main thing is wherever you go, if you're uncomfortable, don't do it. There's nothing wrong with saying, no, I can't do this. Resources are limited. You don't want to waste them. You don't want to go and do something that the local physicians maybe can't replicate. That may not have been the best use of your time and resources. This is a big financial burden on a lot of families. They lose wages. They need to buy the hardware, pay for the x-rays, pay for the pathology, et cetera. So make sure you're really doing the right thing. And I think ultimately, who's going to follow these patients? Are there local therapists, local physicians? Because unfortunately, we're all going to have complications, and who's going to help you take care of these patients? WhatsApp is fantastic, but you have to have a body on the other side of it to really help out. And I think a lot of this is patient family. They provide the post-op care. There's a cultural issues. You have to be culturally competent. Language barriers are a little bit of an issue. So you have to think of all these things in deciding what you're going to do. Ultimately, if it's not safe, it has to be done, you know, bring them home. So there's multiple kinds of trips I just want to talk about a little bit. There's really 4 that are well described in literature, you know, starting with the drop-in missions to kind of the concept of ultimate, which would be capacity building. So I'm going to go over the models, talk a little bit about who you can work with, and then just some general principles to maximize your trip efficiencies. You know, Paul Farmer, way back in 2013, so not about 10 years ago now, worked with leaders from 14 other countries and formed this Lancet Commission, and they came out with this report that Dr. Leversedge just commented on in 2014, prioritizing global surgery. About the same time, Dr. Kozin started the Touching Hands project. So this has all been about 10 years. And if you haven't read this, the paper that came out in 2015 for the Lancet Commission, Global Surgery 2030, it's over 50 pages. It's quite a read, but it's really insightful and thoughtful about where we could take global surgery. So I recommend everyone at least flips through, and it's really good information source. Some of the original papers were actually from the plastic surgeons. Research back in 2011 had some preliminary information on how to do international plastic surgery trips, followed a few years later about cleft lip and palate. And they're kind of who started the ball rolling in this. Kevin Chung, if you haven't read it, the Journal of Hand Surgery in 2017 has a really nice introductory lecture on international outreach and hand surgery. So I think these are three of the bigger initial studies on it. So worthwhile reading. When you decide what you're going to do for a trip, there's really four models of it that people talk about. One is a direct supply or vertical approach. One is a transfer to high income countries for care, or a so-called reverse fellowship. Thirdly is a horizontal approach. And finally, there's a more of a diagonal development, which is, I think, what our goal should be moving forward. The direct supply or vertical approach is kind of the historical. You fly in, fly out, you're self-contained. They're really the original trips. There are advantages to this. You kind of scale the package. You know what you're going to do. You bring everything in, do what you qualify to, and leave. Short duration. Your secretary's not going to kill you. Your patients aren't going to kill you. So it's a controlled situation. I would say there's probably more cons to pros than this. So it's often hard to coordinate with local people. I think you probably, because of lack of teaching, being culturally competent, being able to really anticipate the needs of the local physicians and community, inhibit the development of local connections. And you may alienate patients who have issues outside your scope of expertise. So good and bads to this. But again, I think this was the original that we've really tried to get away from. And again, some of this is commentary. Remember that little editorialization. There's a fair amount of papers about this. Secondly, is transfer to high income countries for required care. This is usually institutional arrangements, more of a reverse fellowship model for complex procedures that may be life-saving, et cetera, appropriate. Microsurgical procedures, certain complex plexus, free flaps, patients that really have significant medical comorbidities, especially some of these babies that have cardiac issues. It's just not safe to put them through surgeries. They may need extensive post-op care. And you may want to try to teach someone a procedure that they don't have the resources so they can ultimately get the resources. These are certainly good reasons to bring the patients to the US, or at least bring the trainees. Some of the cons is really a brain drain. We're not teaching them, we're bringing limited people here, and they may not be able to do the teaching that we could do if we went there. And also they may not have the resources. The third model is kind of the horizontal approach, which is what certain, Kieran, Ethiopia, Scott Cozen has done there for many years. Be First in Malawi is another long-term project. Don Lalonde's gone to Kwanzi in Ghana, long-term projects. So they're really more of a horizontal. These take a long time to develop. The pros are really you get involved in local health infrastructure, you get long-term investment. So if you go back every 6 months, every year, similar to what Fraser is doing now, you can really build long-term relationships, but it takes a long time. Just interesting, this is, Be First is the British Touching Hands, I guess the BSSH Touching Hands. They just started this project. They have a 2.5 year curriculum in Malawi. They started last year. So imagine that they have 2.5 years. You're going to go over every month, lecture after lecture. So it's an onerous task, but once it gets done, that's an incredible way to teach people. So this is doable, but huge amount of resources. It takes a long time to implement. You need a lot of government support to keep this going. And again, how do you measure success? This is a long time to keep someone's interest in hand surgery, but it's an interesting concept. I think probably the best way is kind of this so-called diagonal development people talk about. It combines the dropping in and doing it, being efficient with longer term type thing. So again, immediate benefit, you planning for a long-term presence. You really can have the opportunity to maximize local resources, buy the supplies locally, educate the people locally, probably the way to go. You can provide multidisciplinary follow-up, and everything can be needs driven. What patients you choose, the procedures you do, you can build relationships and get information from local institutions, governments, training programs to get the people, get the procedures, get the follow-up, and set up the infrastructure they can do it themselves. So I think a combination of these two is going to be the way of the future. You really have a great two-way information exchange. Again, you develop these relationships. You can enhance the understanding of global healthcare delivery in both directions, us from them from us. You can really help them develop their surgical, clinical, academic, and some research skills too. There's a lot of people in some of these countries that would like to be involved in research, and we can't forget that too if we can have them involved and empower the local healthcare providers to be able to take care of the communities who they know the needs way better than we do. I'm just going to just comment on a couple papers that I think are valuable flipping through. The hand clinics in 2019 is a great addition because there's every type of trip is discussed in it. Dr. Leversedge mentioned a lot of this, and I'll highlight a few things. Local needs are key. You got to pay attention to available resources. And I think this is most important. You have to plan for everything, but things are going to come unexpected. So you have to be flexible. Flexibility is a key, but you have to plan. You have to really coordinate good patient care, reduce the risk. And at the end of the day, you have to sit down, what worked, what didn't work. Because if we don't do a better job tomorrow, we're not making any progress in helping people out. So you really have to take a step back at the end of the day, make sure you chose the right patients, work with the local people, and that you're going to do long-term good. Another in the same volume, a Dr. AM, I call him because his name's harder than mine. It's a great paper. And the two things, one, he kind of knocks down that body count mentality, which is the vertical thing. Oh, I went to country A, we did 57 cases. It was great. I mean, that's fine, but I think you have to think about that within the context of establishing a long-term relationship. So he recommends getting away from that body count mentality. I think that's a great idea, and thinking long-term how you can go with this. With those different ideas, especially the diagonal, there's different groups you can work with. There's touching hands. I think the ASSH just changed their name to the Hand Surgery Endowment, or AAHS, I'm sorry. HVO, Be First, World Pediatric Project. There's multiple groups. There's multiple church faith-based. There's disaster release projects. There's military. There's U.S. Health Service. There's Navajo Nation. There's multiple groups that are involved based on your interest levels, what you're interested in. So again, in the accountability, I think, whenever you pick a trip, you have to identify a leader, both of the group going and the local group, and you have to communicate. Patient care, I think, is number one. What surgery do, if any? How are we going to do the follow-up? Do the right thing. And moving forward, I really would like to put more effort into data collection outcomes. Education is key. The old, if you teach them to fish, it's way more valuable than going and then you fishing for them. And really use resources wisely, working within the host country. And finally, my favorite person in the world, Peter Stern, in his founder's lecture back in 2013, this is similar to Fraser's last slide about volunteerism, but I think it's really true. And that is it. So thank you very much.
Awesome. Thanks so much, Julie. That was a spectacular synopsis of a big topic in a short time. So we've talked about the history of outreach. We've talked about the paradigm that we should use to frame our trips. So now Dr. Greg Sobol, an orthopedic hand and upper extremity surgeon at Beaumont Health in Michigan, is going to talk about what to expect on these trips. Go ahead, Greg.
All right, I think I got it. First, I want to thank everybody for giving me the opportunity to speak with this respected crowd. Start off, I've been able to participate in outreach for 20 years, similar to the previous speakers, Dr. Leversedge. I had the opportunity as a senior resident, and my task was asked to talk about what to expect on outreach. And it's difficult to say what you're going to expect. Each trip is different, to say the least. But I think a common thing, at least for everyone that I've said, it's been, I don't think it's understated to say it's been life-altering or life-changing experience. I went my first trip my senior year, and I kept going back. We were fortunate. I engaged with a outreach group that would go to Columbia, and this was established. They've been doing it for 25 years now, or 26 years now, and it was an established organization. So it was similar to what Dr. Katarincic spoke about, more of a diagonal, where they established a relationship with an underserved area, started educating the physicians, and it's progressed. So it was a really good situation. So some of the things that you can expect: one, we go with a big group. We bring everybody in a lot of these things. We have the anesthesiologists come with us, CRNAs, scrub techs, nurses. We'll bring a medical student and sometimes a fellow. And it's really a team effort. A lot of times you're going to assume a role that may not be your typical role. You help out wherever needed. Sometimes we're understaffed in lean years. Sometimes we're overstaffed, or we have abundance of bodies, and it's great because you get the opportunity to work with people you normally don't get to work with in your everyday practices at home. This is just some of the pictures of us working with some of the hand surgeons. It's a combined trip. It's mostly pediatric, which we do. So there's pediatric orthopedics and hand orthopedics. And there's times where at the end of the week, where some of the more lecture focused pediatric orthopedic surgeons will go into Cali and give talks. And myself and one of the other hand surgeons are left to clean up some of the lower extremity cases. So we'll do some corrective osteotomies of the legs and get back to our basic orthopedic work, which is kind of fun to get back to doing stuff that we haven't done for a while.
Hey, Greg, I'm sorry to interrupt. We can't see your screen. Can you try resharing? I'm sorry.
Did it go out and come?
No, it didn't pop up. There we go. Perfect. We got you.
All right.
Thanks.
So all right, sorry about that, guys. I figured I'd be the one that lost it, but here we go. So the first screen, this is, I'll go back. You heard what I said though, right? So this is actually the view from the hospital in Columbia. Second screen we got here is, all right. And then here we have a group of the colleagues that we travel with. We have both pediatric and adult orthopedic surgeons and hand surgeons. It's primarily a pediatric trip, which focuses on upper extremity and lower extremity injuries. So, and congenital defects. But what you can expect, everything is different. Each trip is a little bit different, even though we're going to the same place year after year. We see different pathology. It is definitely different from your run-of-the-mill orthopedic office. In my office, when I have residents with me, we often like play the guessing game is what's the woman in three's thumb pain? Is it going to be Decker veins, thumb arthritis, CMC arthritis, or a trigger thumb? And we try to see who's right before we get in the room. Every patient is different. The pathology we see is stuff that you don't see every day. We see arthrogryposis. The area we travel has got a bunch of multiple hereditary exostosis. There's trauma, birth palsies, APERTs. There's storage diseases, the things you remember reading about in medical school and residency, but not really seeing. So it's really a chance to get back to the things that you remembered, but don't really see that often. And terminal deficiencies, things that don't fall into a category. In the clinic room where we have the Smith's recognizable pattern of genetic disorders, where we refer to, it's an older copy, but it's one of the best books we have when we're there, just to kind of go over things and see. So the way our trip works is Sundays, we see the patients that are scheduled for surgery from the trip before that comes 6 months prior, the ones that are pre-op, and we'll also schedule the ones for the following trip. Throughout the week, we'll be seeing patients in clinics, and we operate throughout the week. So it's a clinic and OR throughout the entire week. So occasionally we'll have to add cases that come more on an urgent basis or patients that travel from far away, and you have to be flexible, as it was stated some of the earlier speakers. Not everything can be planned, and sometimes you have to know what you can do and what you can't do and what you shouldn't do, because you have to be sensitive to the patient as well as their economic status and what their follow-up will be. The hospital's different. Everywhere you go, it's going to be somewhat different. This is an indoor-outdoor hospital. When it rains through the center of the hospital. So it's refreshing, not only the sense that it's outdoors, but the whole experience is it's a refreshing from your day-to-day activity from home. That's everyone, when you come back from the trip, usually are telling you, oh, what a good thing you do, how nice that you do these outreach programs. I actually sometimes feel it's somewhat selfish on my part. I take a week away from my family and my kids, and I go and it's a reset for me. I get to appreciate kind of practicing medicine in a different way. And when you come back, you feel a little bit more refreshed dealing with your regular practice again. And you have patients where we are from all over the country. Some of these patients travel great distances. This family has to travel. They're from the mountains. Other families will travel. They live on the shore of the country. The story for one of these families, they have to take a boat to a river, take the river up inland until they got to a city, then take a bus, travel 18 hours. So you really have to be sensitive to their needs. And if they come and your schedule's full, we try to fit people in. So you're not always going to be able to stick to the schedule you have. And you take time to appreciate the differences. I think that's one of the most important things. And a lot of the times when we have the residents, they always want to get into the operating room and spend time in the OR and see the cases in the OR. And I insist that they spend some time in the clinics, and I enjoy it as well. It's not often in our daily practices where you get to spend time and see these diverse patients, also spend time with other colleagues in this profession, where you get to learn from colleagues that you don't see frequently, and just kind of bounce ideas and see how they approach different things. So one of the patients we had several years back, a radial deficiency, they're just as interested in you as we are in them. This guy wanted to wear my loops preoperatively. And the pre-op, post-op, a little different than we have at home. It's the privacy acts are not that stringent. HIPAA's not that stringent. We still do site verification and go over the consents. but all the patients share a common post-op recovery room, and the nurses kind of tend to all of them. Families carry their own medical records where we are. There's no like electronic medical records in this area, so they each come with a big envelope with their charts from previous years. Nothing gets lost. They even have x-rays in them. They have progressed to digital x-ray, and as we've carried on over the several years, it's definitely gotten more advanced. The technology that they have, and I'd say that the physicians that are servicing these patients have gotten better as well. So we are making progress. I think to highlight what you can expect and the differences, this is one of the patients. This was my first year there. This is, again, a pediatric patient. And why I say it's life altering. This is a girl scheduled for an amputation. One of my mentors, one of the pediatric surgeons, said, I think we can salvage the leg. He wanted to take the intertable, the periostomy of the pelvis. He's going to wrap it around the pseudoarthrosis and try to salvage it. And everybody's like, when you get a bunch of pediatric orthopedic surgeons in the room, there's multiple opinions and it's hard for all of them to disagree. Me and the other hand surgeon that go on the trip, we usually are much quicker to reach a decision than the pediatric surgeons, but he went ahead and we went for a salvage and did this. And over the 20 years we've been coming back, the girl keeps visiting. She's had a couple angular deformities, but when you see things like this, it's the change you can make in these lives. I know we make changes at home too, but it's impressive. The follow-up, I think Dr. Katarincic hinted on this, the availabilities of things. So had she had an amputation or like a below knee amputation, the prosthetics in this area, they go to the furniture maker, and they're made out of wood, and they have to get them refit yearly, or as they grow. This was probably about 4 years ago. This is another case that kind of highlights the importance. This was the end of the Sunday. Sunday, all the patients wait in this lobby. This is towards the end. The lobby's already empty. And I'm peering out the door and I see this one girl and I'm thinking, oh, this is going to go one of the pediatric orthopods, because I can see, I'll talk over this because I can play the video. I'll lower the volume. I see she's got some lower extremity deformity. I'm like, well, I'll keep seeing the hand people. This is probably going to be one of the pediatric guys, because I think the next video might show up better. You can see she's walking on her ankles or her lateral malleoli. And that's going to be some work. She traveled from, I think, Buenaventura, which is on the coast. It's like an impoverished area. She lived in a house. They gave us photos where it's like elevated on stilts. And she's been walking like this until the age of 4. She came with her grandmother. Her mom abandoned her after birth. There's another video of her walking. She comes over to us at one point. But this is where she, so she came to the clinic like this. And turns out she had some upper extremity issues. So me and the other hand surgeon, you can see she's carrying the book. So she comes in to the clinic and here we are examining her, and lower extremities, upper extremities. She's got like syn polydactyly, no thumb. And we're like, this was unexpected. She wasn't on the schedule. So the plan for her, we ended up staged fashion, one hand at a time, and then the lower extremities over each visit that we came. We ended up policizing, doing a syndactyly release and policizing. This is one of our residents who's now an attending. As I think Dr. Leversedge pointed out, sometimes you don't have the instruments. He's using a hand drill, which you never used before, trying to stabilize the metacarpal. But these are like just the cases that you don't normally see. She ended up having below knee amputations on both, getting fit with prosthetics. Now she's walking with prosthetics, and she's had both hands syndactylized, released, and policized. But she's sort of like the poster child for the foundation that we work with down there. But these are just incredible changes that you can make. And sometimes you have to think out of the box. We had the other surgeon was with us. Neither of us had done a syndactyly release and a policization at the same time. So it's a little interesting. And then the personal expectations, another thing, I kind of stated it earlier, and I think it was stated before, it's sort of like a revitalization, or like you have to immerse yourself in the culture as well. This is one of the fruits they serve us at lunch. Nobody knew what it was, but we tried it. It's delicious. The empanadas, and you really have a team building with the group that you're down there. The last day of the week, the foundation down where we go always likes to embarrass us, takes us to some sort of event where they make us dance and try to teach us how to salsa. And 20 years, I still don't know how, neither do any of us, but it's always a good time. There's a cathedral that we get to tour sometimes. There was the hotel we're staying at had a quinceañera. The hotel is actually nice. It's improved significantly since the first time. First few years we were staying at a farm with peacocks. And if you ever heard a peacock wake you up in the morning, it's something to hear. And then street food, literally street food. This has been grilled on the street. So it's an opportunity. I think one of the slides said some people go to change or some people go to see. We were able to see and change things there. And then this last trip, we were able to go a local custom, something called Tejo. It's a combination of like bocce ball and explosives. We were throwing these rocks at these explosives on the ground. So you do get to have fun. Usually the last night we do something. This is one of the pediatric surgeons out of Rachel Thomas out of California. But so we do have some fun, but it is great faces, great kids, good time. And this is, I like to show my daughters this film when they're complaining that the Wi-Fi is not working. This is one of the girls with terminal deficiencies who's just resilient. These kids are so resilient and the things that they can do with what they have. And it's similar to what she's putting her prosthetic on. I'll fast forward because I think I might be running long on time, but fixes the leg and then she buttons the pants, no problem. So, I mean, if I had to sum it up, I think it's something, if you get the opportunity to go on a outreach program, it's something that I think it'll change your life. It's definitely life-changing.
Thanks, Greg. I completely agree. It's something that keeps people coming back for a long time.
I had problem not sharing stop sharing my screen last time. I'll try one more time. There we go. I think I did it.
Perfect. You got it. Thank you. So next we have Mary Barnes, an occupational therapist at Tufts University, talking about occupational therapy and international outreach. Go ahead, Mary.
Glad to join everyone tonight. Next slide. Ilian is doing my slides. Thanks. Many people ask me how to get involved in international volunteerism, and this is a list of some organizations that you can volunteer with, and our previous speakers have talked about a lot of other organizations. Next slide. In my experience, most international volunteerism is self-funded, including supplies. And I think a lot of maybe therapists are surprised to hear that. Most people know that AAHS has grants, the Vargas grant and International Volunteerism grant. I was awarded the International Volunteerism grant for a trip in April of 2020, and I'm still hoping to go someday, maybe in 2023. COVID got in the way. Also, the Hand Therapy Foundation has some funding that may be available. Next slide. So all the speakers have touched on how we can make our impact more sustainable. And I think the thing for therapists is to just identify local therapists who are interested in hand therapy, and then to support them in the long term through mentorship programs. ASSH has a companion clinic program. ASSH also has international virtual education and also resources through the International Federation of Societies of Hand Therapy. ASSH also has an international traveling course that's free to participants. And I'm joining you tonight from Buenos Aires. I taught last weekend in Mar del Plata, and next weekend I'm teaching a course in Chile. One discussion that we've had a lot about orthotics, and of course there's really no value in teaching someone how to use orthotics if they're not available, if the materials aren't available to them. Next slide. Ilian, next slide. So I had the great opportunity to meet a hand therapist in Mexico City, Josue Aguilera. Go back. And he actually taught me this, but you can do so many orthotics with plastic materials, and they heat pretty well with a heat gun. You can form them. Next slide. So I actually put an outrigger on this one with using a coat hanger, and I attached it with duct tape, trying to use all locally sourced materials. It worked pretty well. Next slide. Next slide, Ilian. This is one of Josue's inventions, and it made a really nice thumb splint. Next slide. This is a radial nerve palsy splint made out of a detergent bottle. And it doesn't drape like regular orthotics, but it's lightweight, and it was really pretty comfortable. And if really it comes to the heart of what OTs do is OTs make adaptive equipment. And the thermoplastic materials that we use, they end up in the landfill. And this was something that didn't go to the landfill. Next slide. Another great way to, this is another thing from Josue in Mexico City, a pediatric positioning device made out of a 5-gallon bucket. Next slide. Another great way to make our impact more sustainable is the use of 3D printing. And Josue in Mexico City is using it. And also I had the opportunity to meet a brilliant therapist here in Argentina, Fernanda. She's doing a lot of innovation with 3D printing for orthotics. And so people in developing countries, the 3D printer is expensive, the startup, but the materials, she can make a foreign-based splint for about $1 worth of plastic. And the files could be shared. The people in developing countries could do the measurements and send the files off, and they could be shared electronically. Next slide. Just some slides from my trip to Vietnam with Surgicorps. Next slide. Ileana, next slide, please. And also tapping into as many resources as possible for equipment. International Federation of Societies of Hand Therapy donated some goniometers, and I was able to share them with the therapists in Vietnam that I've gone on. I think our assumptions that don't always reflect the reality of what we see. And this OT clinic in Ho Chi Minh City was beautiful. Their physical therapy clinic was as nice as most that you'd see in the US. So we're not necessarily that exceptional. So I think it's important to build relationships with people. And I think it's important to respect people and be open to learning from other people, and to approach with humility. And also, if you have a little extra time, next slide. You can throw in some volunteerism. That's all. Thank you.
Thank you very much, Mary. That was great. I think all of us as hand surgeons know how important therapy is to good outcomes. And so that was a wonderful talk. The last talk of the evening is Dr. Don Lalonde, professor and hand surgeon from Dalhousie University. And he's going to be talking about opportunities for involvement. Go ahead, Dr. Lalonde.
Thanks very much, Ryan. It's a privilege to be here. I started in 1996, and at that time, the big thrill for me in outreach was to see the light in a mother's eyes when she first saw the repaired lip of her child. But now, a much bigger thrill for me is to see the light in a surgeon's eyes when he first realizes that he can now help thousands of patients who previously had no access to surgery. So outreach has really changed for me a lot. This is the Wallant room that Scott Cozen and I started in Ghana in 2017. When I first went to Ghana a few years before that, one of the residents presented a case where a patient could only afford one view of a fractured radius. And he was kind of bawled out by his professor. How come you didn't get two views? Well, the patient couldn't afford it. And, you know, people can't afford unnecessary things in surgery, and they certainly can't afford unnecessary sedation, and they can't afford unnecessary main operating room sterility. And when you eliminate those things like we did in Ghana with this Wallant room, they are now doing 500 cases a year and have been doing that since 2017. And it's less than half the cost for patients. So this is a minor procedure room outside the main operating room, same infection rate, and just good Wallant local anesthesia. So people can now actually afford to have surgery in that city. And we're just showing them what we do in Canada, where we've moved a lot of hand trauma to minor procedure rooms in most cities. And this just makes surgery affordable for the rest of the world. And I think it's really important to spread that model. And those on this call who are interested in doing something, one thing you can go do is you can go to Kumasi, Ghana, and you can do that with health volunteers overseas. You got to foot your own bill, but if you're a plastic surgeon or an orthopedic surgeon, you can teach hand surgery. And they actually have 2 hand surgery fellows right now. These are the first hand surgery fellows who are being trained in West Africa. I did a webinar with them today talking about nerve compression. They don't think they have carpal tunnel syndrome over there, but they do. They've just never looked for it. And the same thing is happening in Kenya. This is Ankit Dave, who's an orthopedic surgeon doing a distal radius in Kenya, and other surgeons doing Wallant surgery in Kenya. In fact, COVID was very good for the spreading of this. And you're looking at Pankaj Jani, who is one of the authors of the Lancet Commission. And he's a total believer in Wallant, and he and I organized many webinars through COVID. And in fact, he started 16 hospitals doing minor procedure rooms, just like the one you saw in Ghana, in Kenya. And he's a big believer in doing this to make surgery accessible, because that's the whole problem, as Julie Katarincic mentioned earlier, is accessibility. So what we're doing here is making surgery accessible where it was not accessible, and affordable and safer, because the mortality rate from general anesthesia is significantly higher in Africa than it is in North America. I went to Rwanda this February, and I gave lectures in 3 hospitals and started minor procedure room surgery in 3 hospitals. And there were 2 surgeons from other hospitals who was there. The video that you're seeing play below was from a general surgeon from another city who just happened to be in Kigali to see the lectures. And she went home and did a spaghetti wrist with Wallant. And I think that if you're interested in teaching Wallant, that this is a really, really helpful thing to do. And just to go back, if any of you want to go to any of these countries, any of these hospitals, I'm delighted to introduce you to people who would love to learn Wallant from you. If you're a Wallant surgeon at home, it's a great skill to share. So here I am with 9 plastic surgery residents in Rwanda. There's only 4 plastic surgeons in the country, but they got 9 in training, thanks to Pankaj Jani. And here we are doing the first minor procedure room cases at one of those 2 hospitals in Rwanda. And some of them we used augmented field sterility because they were longer. others shorter cases, just straight up field sterility. And the residents by themselves did a spaghetti wrist in this minor procedure room 6 days later. They got, if we think we have access to OR problems, man, they got terrible access to OR problems. So these minor procedure rooms really solve the problem. I was helping Dr. Yves Nazarwa do a radial nerve palsy in the main operating room, but we did it with Lalonde to decrease the cost of unnecessary sedation. And here we are at the end of a triple radial nerve tendon transfer case. It actually was my first one and his first one, but we managed to do just fine. We got some wrist extension and some finger extension and some thumb extension where there was none. And so empowering them to do that is huge. This was one of the best parts of the trip. I gave a talk to over 40 surgeons of all stripes at the military hospital in Rwanda. And this guy was in the audience. He's a urologist. And he came to me at the end of the day with a great big grin on his face because he left my talk about tumescent local anesthesia, went to the OR, and he was told that his first case was canceled because there was no beds. And so they couldn't admit the patient after general anesthesia to take out this big bladder stone that you're looking at the bottom of the screen. And he said, wait a minute, you're not canceling my case. I need lidocaine, adrenaline, and saline. And he did a suprapubic extraction of this huge bladder stone. And his case was not canceled because he learned how to do tumescent local anesthesia in a 40-minute talk. And so some people hear about this for 10 years and never do anything. This guy took it after 40 minutes and brought it across the finish line. And here he is digging out the bladder stone through the suprapubic incision. You know, every hospital has a person in charge of ordering supplies. And when I started on these trips, I'd go, oh, gee, that's too bad. All you have is giant needles, and all you have are slip lock syringes that blow off and give everybody an anesthesia shower instead of Luer lock syringes. But every hospital has a person who orders things. So in Rwanda, I went and sought out those people with the local surgeons. And I said, here's the guy who can get that stuff for you. And they went, yeah, we can get that stuff. So just because that's all they happen to have is just because the person at the order screen isn't ticking the right box. So one of my favorite things to do now when I go to these trips is I go to the box ticker and I say, no, don't order the giant ones. Try ordering the 30 gauge needles. COVID enabled a lot of webinars to Africa to start wide awake hand surgery, minor procedure rooms. And if any of you are interested in going to any of these countries, I'd be happy to introduce people to you in those countries who would love to have you come and share Lalonde knowledge with them. And here's what happens. One of the surgeons, because most people that we're talking to are not hand surgeons. These countries don't have hand surgeons. They just got general surgeons. And if they're lucky, they might have plastic surgeons and orthopedic surgeons. So this is a general surgeon who took the knowledge of tumescent local anesthesia and used it to do a cancer excision. I helped him publish this. And so if you have frail people, this was a frail patient with breast cancer, he was able to perhaps save this person's life. And this is another surgeon from Kenya who also attended one of these webinars that we gave during COVID on tumescent local anesthesia. And this is a very frail diabetic who came in who was very, very sick, and the anesthetist didn't want to put him to sleep. And so they did his leg amputation with Lalonde. And so a lot of these surgeons take the skills that we give them and use them to do other things. Here you're seeing distal radius fracture being done in a number of countries, but the top center is malunion of the radius, which is what we usually see in developing countries. And so distal radius is a chip shot compared to that, but Kamal Rafiki from Morocco used it to do an osteotomy and make a forearm straight. You can also do more complex things we now know, like elbow fractures and so on. But just a word about unnecessary solid waste and expense in the main operating room. In our hospital, we used to require this much sterility to do a tiny little ear nubbin, and that's the garbage that we used to throw away to do that. We can now do field sterility in our main operating room, but this is the kind of money that people in developing countries can't afford to throw away. We might be able to afford to throw away that in the United States and Canada, but they can't. So if you eliminate all of that foolishness, and there's no difference in the infection rates. There's excellent evidence that certainly soft tissue procedures like carpal tunnel have just as good an infection rate in a minor procedure room with field sterility at 0.4% as in the main operating room. And most surgeons all across the United States, their standard of care is field sterility, and they have a 0.4% infection rate as well in this case series of 20,000 cases. So this addiction to the main operating room sterile field is totally unnecessary. We published this paper just last fall on K-wires, 1,000 patients, half of them in the main OR, half of them in minor procedure rooms in Canada. No difference in infection rates. And you know, all you need to take surgery out of the main operating room is 5 basic instruments. And that's how we started it in Ghana and Kenya. I brought 10 minor procedure room sets. That allowed them to do 10 cases a day outside the main operating room. That's all they need, is something very simple to kickstart them. And since then, we've bought and donated many of these sets. We've bought 60 hospitals worth of sets for Kenya, and they're being distributed by Pankaj Jani, who I introduced you to earlier, one of the authors of the Lancet Commission, past president of COSEXA, who has trained hundreds of surgeons in East Africa. And he only gives the instrument sets out to surgeons who are actually going to start minor procedure room surgery in their hospital. He does not give the instrument sets to surgeons who are going to take them to their private offices. And then finally, we're doing a Wallant workshop for 10 surgeons, or for surgeons from 10 African countries all around Kenya. This is being sponsored and supported by IFSSH, BSSH, and the American Association for Hand Surgery. And I'm pleased that ASSH and AAHS have collaborated to do this webinar tonight. Thank you. I'll stop sharing.
Thanks very much, Dr. Lalonde. That was inspiring for sure. And I think all the talks tonight have been wonderful. I want to open it up for, very quickly, be respectful of everyone's time, but open it up for any questions that people in the audience have. You can put it in the chat box or unmute. Does anyone have any questions for the panelists? All right. There's a question from Vanessa Smith. Have you seen any use for APPs in these settings? Any of the panelists can answer too.
I can speak to that. We've had APPs down in Honduras. We actually have one coming down in 2 weeks. It's actually a fantastic opportunity for them to spend time with other physicians. If it's your own APP, for example, it's also a great opportunity for them to sometimes be in the OR where they may not be in the OR, and really see a real link between the surgeries, the decision-making, and the surgery. But I think it's everyone is all hands on deck. So everyone finds their different roles, and the APPs are no different than the therapists that are there, the surgeons are there, and we all pitch in.
Definitely agree. For Dr. Lalonde, what Lalonde solution are you using? And he had a question, do you use bicarb as well?
Some countries don't have bicarb. You can do it without bicarb. It hurts a little more, but most countries do have bicarb. And we have to make it from scratch usually because a lot of these countries haven't gone to the person who orders the lidocaine and says, hey, why don't you order that stuff with adrenaline? It's the same cost. So I'm helping them do that now. But most of the time they have to make it up from scratch. So we make 1% lidocaine with 1 in 100,000 epinephrine, and then just to mess it up. If you're doing a triple forearm tendon transfer and you need 200, you take 150 cc's of saline and 50 of local, and the same for forearm fractures and elbow and so on.
I was going to ask, Greg, maybe you can speak to younger surgeons who are going on these trips for the first time. And you talked about how some of these cases can be intimidating. Any advice you have for young surgeons who that may be a barrier for them?
Yeah, I don't forget your training, because most things that you do, you're trained for, you're well trained, you're coming out of fellowship, wherever you are, you're well trained. And it mostly comes down to basics. And I'll be honest, when we go down there, I usually take a book with me. I'll go back to some of these cases, like some of the stuff you're not prepared for. And I have texted some colleagues when I'm down there. I'm like, hey, what do you think of this? The internet's great. We still have that. So, and I think we're always learning as surgeons, as physicians. There's always room to learn. You learn from colleagues, you learn on the job. And these are great learning opportunities. I think when you stop learning, it gets dull. That's another, and that's what I said when I come back from this trip. It really resets you. You see I have university practice, I have residents, but you also work in a suburban practice, and you have patients complaining about their, tender carpal tunnel scar, and you just get back from Columbia doing, like, it kind of makes it easier to take. I can go another 6 months with that till I go again.
Definitely keeps things in perspective. Well, thank you again to all the panelists. I'm going to turn it back over to Dr. Jane to conclude our session here tonight.
Thanks, Ryan. You did a wonderful job moderating. I would like to thank the faculty for really, truly inspiring talks. So I think I took away a lot from it. I'd also like to thank the Hand Society for the collaboration and putting these talks together. And I want to thank our viewers for spending their evening tonight with us. We appreciate it. And I want to put a plug in for our upcoming webinar. So let me just put this up here. Let's see. I don't think I'll be able to share it. For some reason, it's not allowing me to. But in about 3 weeks, we have our combined webinar series with the American Society of Reconstructive Microsurgery, Demystifying Upper Extremity Flaps. So please join us for that. Same time. Good night.